Please allow me to now introduce our speakers for today's session. Dr. Janet Thomas, Professor, Genetics and Metabolism, Children's Hospital, Colorado, and Shayna Swihovec, Instructor and Certified Genetics Counselor, Genetics and Metabolism, Children's Hospital, Colorado. Thank you all for joining us today. Now let's begin.
Working on it here, hang on.
No worries. Take your time, Dr. Thomas.
There we go. Oh, now it did it again.
Mm-hmm.
I know
Display
this.
settings.
There.
Yes.
Oh. So good afternoon, everyone. I'm Janet Thomas. I'm one of the metabolic and genetics docs here at Children's Hospital. Been around here for quite a while. So today we are presenting the Genetics Virtual Education Series, and as Sabrina said, it is on neurofibromatosis type 1. I will do the first part of the presentation, largely on diagnosis and management, and then Shayna will do the second part of the presentation on the genetics and inheritance of NF1. So we have no conflicts to declare on this topic. And here's our objectives, sort of as stated. We're going to review the clinical presentation, diagnosis and management of NF1, and discuss the inheritance and genetics of NF1. And as you likely can understand, we will use NF1 probably a whole lot more than we'll use neurofibromatosis type 1. So, so what is NF1? NF1 is a neurocutaneous disorder and an inherited tumor predisposition syndrome, which primarily involves the skin and the peripheral nervous system. I would also add here probably also significant involvement of the central nervous system. It is a relatively common genetic disorder. For those of us in genetics, we see a fair amount of NF, has a population prevalence of approximately 1 in 3,000 individuals. It is typically recognized in early childhood, but the phenotype certainly evolves with time and with age. It is a condition that has widespread health implications and a wide spectrum of health implications, but it should not be confused with NF2. We have many families that come in and wonder if NF1 will become NF2, and of course the answer is no. They are two separate conditions and are quite different. The pathophysiology of NF1, it is caused by variants in the NF1 gene, which is located on chromosome 17q. And the NF1 gene encodes for a protein called neurofibromin. And neurofibromin is a RAS gap protein. So it's a RAS GTPase activating protein, which stimulates conversion of bound GTP, which is the active form, back to GDP, the inactive form on RAS. So neurofibromin deficiency thus results in elevated RAS signaling. And as you might recall, RAS proteins function as fundamental signaling switches controlling a multitude of cellular processes, but importantly, normal cell growth and differentiation. And
Excuse me, Dr. Thomas, I am so sorry to interrupt. My sincerest apologies. It looks like a portion of your screen is cut off, so we're only seeing half of the presentation instead of the full screen.
Oops, so what?
Okay, that's perfect. That's perfect. Thank you so much.
I didn't do anything.
It just went right back to, it went to the normal format, so we're good to go. Thank you.
Okay. Perfect. Thank you. Thanks for interrupting. That's fine. So again, this is in the RAS pathway, which is very important in normal cell growth and differentiation. And hence, NF1 functions as a tumor suppressor gene. So visually, this is a really complicated pathway. This is from an article as referenced below. I will mostly point out, let me switch my pointer here. Here's NF1. This is the RAS pathway here. This is the RAS active form with GTP. Neurofibromin helps to bring this back to the inactive form. But when NF1 is not functioning properly, you can see the whole gamut of signaling that occurs as a consequence of an active RAS pathway. And importantly, down here is proliferation and cell growth. So the diagnosis of NF1 is largely based on clinical criteria. Most recently, this nice article published in Pediatrics and sponsored by the American Academy of Pediatrics is a revised health supervision for children with NF type 1. This came out last year. It was an update from a previous version and is a very nice comprehensive article, so it's a good resource for review. Out of that article came this table. This is an NIH Consensus Development Conference criteria for NF1. And NF1, the diagnosis of NF1 is largely based on clinical criteria. So we look at a variety of things from the standpoint of skin, mostly skin findings and other findings to help us make the diagnosis of NF1. And we will go through these individually in the next several slides, but we look at things like cafe au lait macules, freckling, neurofibromas, the presence of an optic glioma, Lisch nodules, some bony, very specific bony features, and then, of course, a first-degree relative. To this list, though, I would also now add that if we find a pathogenic variant that's identified in the NF1 gene, that also is one of the clinical criteria, but does not necessarily make a diagnosis kind of straight out if you don't have other clinical findings. So we'll walk through some of the clinical features of NF1. First and foremost is cafe au lait macules. These are usually the first finding in children, and many children often have these at birth. So a family may notice, 1, 2, or 3 or more cafe au lait macules initially at birth, and then the child develops more with age. They tend to be uniform and regular in their edges. They're flat, and they are purely cosmetic. So we look for 6 or more cafe au lait macules from a diagnostic criteria. In little ones, those are greater than 0.5 centimeters. In kids over puberty, it's 1.5 centimeters. But after you get 6 or more of the appropriate size, the number doesn't tell us much. And I always tell the families, don't drive yourself crazy counting cafe au lait macules. They do not predict severity. So a child might have a whole bunch of cafe au lait macules, but have relatively limited other signs of neurofibromatosis or vice versa. It is very common in the general population to have 1, 2, maybe even 3 cafe au lait macules and not have NF1. The second feature that is most commonly seen in kids is skin fold freckling. So from a diagnostic standpoint, we look at the axillary area and the inguinal area. We typically see this in kind of older toddlers, young childhood, 3 to 5 years of age, as the time when we start to see the skin fold freckling. This too is purely cosmetic, so both the cafe au laits and the skin fold freckling are purely cosmetic. They don't cause any problems. Some children and older individuals will develop more diffuse skin fold freckling, or say freckling around the neck area. But again, from a diagnostic standpoint, we are mostly looking at the axilla and the inguinal areas. The next feature that will typically emerge in later childhood and into the teenage years are the neurofibromas. From a diagnostic standpoint, we want 2 or more neurofibromas as one of the criteria. And typically, numbers of neurofibromas increase with age. So in younger kids, we don't see them very often. As kids start to hit school age and a little bit older, we might see them. And then the typical appearance in adulthood, you'll see it on the next slide, and if it gets real severe. I typically see neurofibromas initially appear on the trunk. These are the neurofibromas in a young child on this first initial picture over here, as well as these. They can be quite flat to the skin, or they can be a little pedunculated, and that's probably, there we go, a little pedunculated to the skin as well. In very young children, and often when we're first starting to see them in children, they often appear as sort of a purplish hue, sort of seen in this picture up here. And they might be more of a filling defect rather than a true bump. So if you ran your finger over them, they actually might dip in a little bit rather than being a true bump. These little cutaneous neurofibromas are not at risk for malignant transformation. They tend to be only bothersome, and we only tend to remove them if they're in a spot that like rubs, like a belt line or shoe line, something like that, where they cause problems in that regards. They can be removed and can be removed pretty easily if they're in a spot that bothers the individual. This is maybe, I can't say it's a real typical pictures of adults with neurofibromatosis, but certainly this is not what we classically see in children with neurofibromatosis. But as I mentioned earlier, the number of neurofibromas increases with age, and you will certainly see individuals that can be just literally have hundreds and thousands of neurofibromas. This is the other reason that we don't try to remove them, because trying to remove all of them is just not possible. I have also seen adults, typically parents of kids, that have, we've made the diagnosis in the parent after we make the diagnosis in the child, because the parent has such mild signs that they weren't concerned about their few little bumps that they had. Other skin findings that are not part of the diagnostic criteria but are seen frequently in kids with NF1 are juvenile xanthogranulomas, so these little orangish yellowish papules here. These are always a little bit of bothersome for the family. They always typically point them out, but they're not particularly harmful, and they usually go away with time. You can also see this hypopigmented area, fancy name of nevus anemicus, I can't even say it. And then also really commonly is pruritus. These kids can be itchy. Sometimes it's diffuse itchiness, and sometimes just itchiness over some of the neurofibromas. Another diagnostic criteria, of course, is the plexiform neurofibromas. These are the problematic neurofibromas, if you will. Most are felt to be congenital, but actually become evident during childhood. They're found in probably about 50% of individuals with NF1, but less than 20% require any intervention in childhood. Many of the plexiforms will have overlying skin changes, so you can see sort of an overlying hyperpigmentation in this plexiform here. Sometimes it's a thicker skin change, and sometimes it's even just hair that overlays this area. These two, in and of themselves, are benign. They don't cause problems in that regards, but they cause problems because of location. But it is the plexiform neurofibromas where there is a risk of malignant transformation, and we'll talk about that in a little bit. You only need one plexiform neurofibroma as opposed to two of the cutaneous neurofibromas from the standpoint of the diagnostic criteria. These can be actually quite small, you know, quarter size, dime size, or they can be quite large. These are harder to remove if you do surgical excision. I always describe them as sort of finger-like extensions into the surrounding tissue. So it's much more difficult to remove all the tissue when you try to remove a plexiform, and hence there's a risk of regrowth if these are removed. So this might be on the left-hand side or right-hand side, whatever way you're looking at a computer, what we typically see in children. But if the family has Googled at all, it is a variety of very scary pictures that the families will see when they Google NF1 and look at plexiform neurofibromas. So these are all plexiform neurofibromas, including this asymmetry in this woman's leg is plexiform neurofibromas. So we do, of course, tell families try not to Google because they actually come in very, very, very concerned with these presentations. In addition to the really visible ones, individuals can have plexiform neurofibromas internally, of course. So here's a variety of pictures of a big plexiform here in the posterior neck area involving the spinal column back here, making some signal changes in the spinal cord here. Here's a big abdominal plexiform. Here's some that surrounds the nerve roots in the lower spine through here as well. A big one across the shoulders of this individual into the neck, and again, lower spine as well. So plexiforms can occur anywhere. and they do cause significant problems, again, because of location. Even if this one, for example, this big one in the abdomen didn't have malignant change, it's certainly going to cause problems just based on its size, as that would be very evident. So back to the diagnostic criteria. One of the other diagnostic criteria is Lisch nodules. These are found on the eye. These are iris hamartomas. We often describe these as like cafe au lait macules on the iris because nicely they do not affect vision, but they're very specific to NF1. So if an eye doctor was doing an eye exam on an individual and he saw these, he would be highly suspicious of NF1. The occurrence of this finding, too, is age-related in that we do not typically see it in very young children. About 50% of the kids by the time they reach school age will have Lisch nodules, and then certainly much more so in teenagers and young adults. You need 2 or more Lisch nodules from a diagnostic standpoint. The other eye finding that we look for, not only from a diagnosis standpoint, but also from a long-term management standpoint, is an optic pathway glioma. Of course, you only need one of these from a diagnostic standpoint. But most commonly, this is the most common CNS-related tumor that we see in children with NF1, and it's 15 to 20% of the children have optic pathway gliomas. That being said, most remain rather indolent and actually don't need therapy or need any treatment. We tend to only treat these if we're seeing visual changes or other evidence of clinical and symptomatic involvement. This is one of the main reasons that we do annual eye exams in all the young children, as this is a tumor that's most frequent in kids 6 years of age and less. So we have always recommended annual eye exams in the very young children with NF1. The other typical presentation of an optic pathway glioma is actually precocious puberty or also acceleration of linear growth. So if we see that, that also triggers us to do imaging looking for an optic pathway glioma. As mentioned earlier, you can see a variety of bony dysplasias. The most common is tibial dysplasia. As you can see here, this curve in the tibia, this is usually typically anterior or can be lateral in the tibia. This, of course, leads to a risk of fractures and pseudoarthrosis. So it can cause a lot of problems in that regard. And interestingly, more than 2/3 of infants presenting with congenital tibial pseudoarthrosis have NF1. So it's a significant feature, although admittedly clinically we don't see it all that often. There's a lot of other findings that we see in NF1 that are not related to diagnostic criteria. So from a skeletal standpoint, we see many children that have macrocephaly and or short stature. They don't always go together. These are not diagnostic criteria, as I mentioned, and they also, what we want to see in growth is even if the head circumference is large or the stature is short, we want to see individuals tracking along their growth curve. So it's very typical to have the short stature but be tracking. So what we don't see and with NF is if you see a big either jump in head circumference or a drop in stature velocity, that is when it needs further evaluation. But if they're tracking along the growth curves, we become quite a bit less concerned as in typical pediatrics. Sphenoid wing dysplasia is the other bony dysplasia that can be seen, can be part of the diagnostic criteria, although we don't do a lot of that imaging to pick it up. If we do see it, we think a little bit of periorbital plexiform neurofibromas that may be involved in that area. We screen routinely for scoliosis. I always describe the scoliosis as coming in sort of 2 forms. You have your sort of mild form that you might pick up on a typical clinical exam, monitored over time but never needs intervention, or more rarely is a fairly dysplastic and fairly aggressive scoliosis that needs intervention rather quickly. Leg length discrepancy is also seen. And as I mentioned earlier, if you see a significant discrepancy, maybe not so much in leg length, but perhaps leg circumference, arm circumference, those sorts of things, think of plexiform neurofibromas. And more recently, it's become evident that many children with NF1 have low vitamin D and probably should be supplemented, although it does not appear that they have an increased risk of fractures. Other things that we routinely monitor for are hypertension. When we see hypertension in the children, we go looking for sort of an anatomic reason. So is there some renal artery stenosis? Is there coarctation? Is there neurofibroma sitting close to the kidneys and pushing on the kidneys? In adults, about 10% of the adult NF population has hypertension, and that is more often kind of the idiopathic run-of-the-mill hypertension that we can all get. It can also be a symptom or a sign of a pheochromocytoma. So we tend to pay attention to that and routinely monitor blood pressure. Constipation and abdominal pain is often a common kind of complaint in about a third of the kids with NF1. This, however, is rarely associated with internal plexiform neurofibromas or internal neurofibromas contributing. So more often than not, we treat with, as one would, other complaints of constipation and abdominal pain in other children. From an central nervous system standpoint, probably the most common thing we see, especially on imaging, is T2 hyperintensities. We used to call these UBOs, or unidentified bright objects. These can mainly occur in the basal ganglia. They can occur in the brainstem and the cerebellum. Interestingly, these don't seem to cause problems. Of particular note, they have in the past tried to correlate these findings with such things as learning disabilities and those sorts of things, and there's been no proven association. We see these very frequently in young children when we do central nervous system imaging. If we image those same children when they're young adults, we no longer see these bright spots, so they do tend to go away with time. Other CNS findings might be low-grade gliomas, which can sort of occur anywhere in the brain. Migraine headaches, and particularly migraine-like headaches, are quite common in NF, as more rarely seizures can be seen in NF, but that's actually quite unusual. And then you can also see some cerebrovascular abnormalities, especially some stenotic lesions and moyamoya syndrome. Again, rare, but notable. So people often ask about indications for neuroimaging studies with children with NF1. This table came out again of the pediatric article. And I would tell you, as I mentioned earlier, that we don't typically do routine imaging, so we don't do baseline imaging, and we don't do annual imaging for any reason with kids with NF1 without clinical indications. So for us, the most common clinical indication for doing imaging is probably headaches, new onset headaches, or if someone's had headaches, if there's been a change in the frequency or severity of headaches, we tend to do imaging. The other one to particularly note is precocious puberty. As I mentioned earlier, a lot of the children that present with precocious puberty will have optic chiasm gliomas. But of course, seizures, any evidence of intracranial pressure, stroke-like symptoms, change in vision, other clinical presentations prompt imaging as well. I mentioned malignancy earlier in NF1. We do see this in NF1, not as frequent in children as we do in the adults, but frequent neoplasms in children include the malignant peripheral nerve sheath tumors, gliomas, leukemia, and pheochromocytomas. The malignant peripheral nerve sheath tumors usually arise by malignant transformation in an existing plexiform. Again, the big plexiforms, not the little nodular neurofibromas. And for individuals with NF1, there's actually a lifetime risk of 8 to 13% to develop a malignant peripheral nerve sheath tumor, typically during or after young adulthood. So again, not very common in young children. Unfortunately, these tend to be quite aggressive tumors, and the 5-year survival for these tumors, even with therapy, remains at less than 20%. If an individual has a plexiform that you're sort of watching and monitoring, there's several signals that may tell us that malignant transformation is occurring, particularly the development of pain, particularly if that pain is persistent or awakening the patient at night, rapid growth of the plexiform, and or a change in consistency going from, say, a soft, pliable plexiform to something that's more firm and hard. That might signal the malignant transformation, and that's what I counsel families on to watch. Make sure you let someone know, because that will usually prompt biopsy and or excision to make sure that we get on top of it quickly. Other malignancies that are seen, again, more common in adults and children, are a variety of astrocytomas, rhabdomyosarcomas, the gastrointestinal stroma tumors, the GIST, and now we recognize an increased risk of breast cancer in women. It's early onset breast cancer, so new recommendations have arisen that mammograms start at age 30. It does not appear that the women are at increased risk for later onset breast cancer. So if they reach 55 to 60, they're at the same risk as the population. So this is younger, earlier onset breast cancer. Malignancy, mainly the malignant peripheral neurosheath tumors and cardiovascular complications are the major causes of reduced life expectancy in NF, but this is mostly in adults, and the life expectancy in general is decreased by 8 to 15 years. Switching gears, neurodevelopmental findings are often quite common in kids with neurofibromatosis. So infants and toddlers may demonstrate mild motor delays. This typically improves during infancy or during childhood, and there may be an increased incidence of speech and language difficulties. In addition, we see about 50% of the kids have some type of learning disability. There's no one specific learning disability, though, that is common, so it's variable. And about 50% of the kids have attention deficit hyperactivity disorder. True intellectual disability is actually quite rare. And if we do see that, then we consider an NF1 deletion. Shana will talk a little bit more about this next. We see some problems with executive functioning, nonverbal learning disabilities such as reduced processing speed, and sometimes difficulty with some of the social pragmatics, delayed social maturity, and anxiety. So for a lot of our patient population, we strongly recommend neuropsychological testing, and many of these kids may need IEPs and 504 plans for school. Again, management guidelines are published in the pediatrics article. Out of this, what we do in our clinical evaluations when we see these kids in clinic, we pay particular attention to blood pressure. The recommendation now is at least annual. Previously, we used to say twice a year. For children, I usually say with every medical visit for the well-child checks to make sure blood pressure is checked as part of vital signs. In addition, we look for scoliosis with a clinical exam. We make sure all the kids have annual eye examinations. This new recommendation is through puberty rather than through our previous recommendation of through age 8 for annual exams. And of course, talk a lot about development and the need for potential neuropsych evaluations and services. So in conclusion, NF is actually a very multi-system disorder and is actually progressive in nature. Approximately 1/3 of patients with NF will develop a serious medical complication in their lifetime, so not necessarily in childhood. There's a very large variability in the clinical manifestations and in the progression of these features. And unfortunately, it is not possible to predict prognosis in childhood. And of course, that's difficult, of course, for families to understand and deal with. There is a brighter future, though. There's a lot of new therapeutic products being developed and a lot of clinical trials currently ongoing. The most recent one is selumetinib, if I said that correctly, or Koselugo. This is a MEK1/2 inhibitor. It's an upstream regulator of the ERK pathway, and this has recently, this year, been approved for children greater than 2 years of age with symptomatic or inoperable plexiform neurofibromas. So going back to this diagram, here it is here. Here's the MEK pathway upstream from ERK, which you can see is involved in cellular proliferation. And studies have been very promising that this helps reduce the size and reduce the growth of plexiform neurofibromas. It doesn't get rid of them, but significantly reduces the size of plexiform neurofibromas. And some of the other drugs, oops, I'll go back, All these in red are other drugs under clinical trial investigation that are also being investigated and hold a lot of potential for individuals with neurofibromatosis. I'll briefly mention one of the best resources that we provide families is the Children's Tumor Foundation, and that's a national organization that has largely research funding for neurofibromatosis, and we will save questions for the future. Thank you. On to Shayna.
Hold on, sorry, my computer just logged out. More timing. Right. Everyone can see my screen okay?
Looks good.
All right. So as mentioned, my name is Shayna. I'm a genetic counselor at Children's, and I'll be covering the genetic counseling aspects associated with NF1. My basic overview, I will briefly cover some basic genetics, but primarily try to focus on the genetic testing and genotype-phenotype correlations. And then there's just a couple other considerations that we think about as well when we're talking about NF with our patients. So I apologize for the blurriness of the one photo there on the left, but NF1 is an autosomal dominant condition. So that means there's a 50% risk to pass that on to future children. One copy has a genetic change in it that prevents it from working properly, whereas the other copy of our NF1 gene is working the way that we would expect it to. One question that I often get is if there's a sex preference for this condition. So I feel like that the photo on the right there with the gendered children, you can kind of, it gives a better indication of the fact that it is not. It is autosomal, meaning there's no sex preference. So 50% risk regardless of gender. And then one other thing that we think about is that 50% of pathogenic mutations are inherited from a family member coming from mom or dad, but 50% of them are de novo, meaning brand new in a child or individual. So we often get questions as well about, well, there's no family history of this, and no one else in my family has this. How could this possibly have happened? And it's actually not that unusual for us to see brand new changes in children, and that's an interesting one to explain to some families. And one thing that Dr. Thomas touched on as well, but that is really important in this condition, is variable expressivity. So it is a spectrum. Most people are on the mild spectrum, and like she mentioned, we can actually diagnose parents along with the child, and that's something to really keep in mind when you're having that conversation with families about diagnosis and genetic testing, that this could be a surprise that a parent is not thinking about. They're focused on their child, but could come back with a diagnosis themselves. So when we talk about testing, like Dr. Thomas mentioned, it is part of the criteria, but not a huge part of the criteria, in the sense that it is primarily a clinical diagnosis. You don't need the molecular testing, but when we do it, it is sequencing and deletion duplication. We will sometimes do a chromosomal microarray as well if there is a clinical or molecular concern for a full gene deletion. And I'll talk a little bit more about what those clinical concerns might look like. But if we were seeing, a full deletion on that sequencing test, then we might think about doing that microarray to help understand those breakpoints and what other genes might be involved. We typically send our testing to the University of Alabama. They have a fantastic program for NF, and they do a lot of really good research on these mutations. So in an ideal world, that's where we would go. That being said, their testing is pretty expensive, and insurance doesn't tend to cover it because it isn't going to change any of this management. If you have it, it's a clinical diagnosis again. So no matter what you get on genetic testing, if it's positive or negative, we're going to do the same management. All of the things that Dr. Thomas was talking about, we're doing if you have cafe au laits or you meet clinical criteria, regardless of this testing. So that does make it hard for insurances to want to cover it. So there are more labs now. One that we primarily use is Invitae that has fantastic self-pay costs for families. This has made this a lot more accessible for those families that do want this testing. So we are seeing a kind of an increase in people doing this testing. A couple things to consider when you are offering testing to a family, or when we offer testing, is 5% of the time we can't find a mutation. So this does absolutely not mean that someone doesn't have NF1. You can still have NF1, we just can't find that mutation. So I do have a lot of families coming in with the misconception of, well, we had negative testing, so we must not have this condition. And it can be a bit of a heartbreaker to say, you know what, no, we still need to do all of this management because 5% of the time we can't find this change. The other thing to consider, just like with any genetic testing, is that variants of uncertain significance can be present. It happens less often with NF because we do know more of the mutations, but it still can happen. One places that it happens, and not so much in the pediatric world, but a lot of times we'll see variants. NF1 is actually on breast cancer panels, like Dr. Thomas mentioned. There's breast cancer risks. So on typical, adult cancer panels, NF1 is on there, and that's a lot of the times where we can get some of those variants. So that's something to consider if you're thinking about cancer testing in the adult world as well. And then again, we both kind of harped on this a bit. There's no management changes with a positive or negative result, and that can be kind of hard for some families to wrap their heads around. Why would we do this testing then? What's the purpose of this if it's not going to change management? And that's where we come into recurrence risks a little bit. This is primarily where we would think about this testing being helpful. So there are preconception and prenatal testing options that exist today to help avoid that 50% risk for families, but that isn't available if we don't have the mutation. So if we can't find it, there isn't anything to test for. We don't just go sequencing the NF1 gene in a fetus, so we needed a targeted test to do that. The other caveat to this no change in management is the potential for another condition called Leigh syndrome. So Leigh syndrome looks really similar to NF, particularly in babies and toddlers, because that's before they develop some of those neurofibromas and other features that we'd see later in childhood. So that's another reason that we would consider testing or recommend testing in the younger kids. So Leigh syndrome, just a brief overview, has very similar features, like I mentioned, in terms of the skin findings of multiple cafe au laits and freckling. So those benign cosmetic features that Dr. Thomas was talking about. We do still see larger head size as well as learning delays, but we don't see any of the neurofibromas, Lisch nodules, optic gliomas, or other bony abnormalities. So the things that typically cause the complications and require treatments are the things that we don't see with Leigh syndrome. So this can limit some of that screening. Like, we don't recommend annual ophthalmology exams for our patients with Leigh syndrome. That can be really reassuring to families if it's especially a baby who has a couple of cafe au laits and they want to know if this really is NF and we need to do all of this screening, or if it's Leigh, then we can be a little bit more relaxed on that management. That being said, Leigh is really, really rare. More often than not, it's NF and not Leigh syndrome. But because it's rare, we do have a really limited sample size. That's important when we're thinking about the phenotypic data. We don't have a lot of that. So as of now, we haven't seen anyone with neurofibromas or any of these other manifestations, but we don't know if there's anything maybe that we're missing, or just something that hasn't come up yet. So we do still typically follow these kiddos in our clinic just to make sure that there's nothing that comes up. Even without those eye exams. And then most places now are doing spread 1 testing and NF testing at the same time, just to help limit some of that uncertainty. And UAB has an option to do them both together, which is, again, University of Alabama, and then so does Invitae. We can add those two together for the same cost. So they make it pretty accessible, like I said. So just to overview benefits and limitations of testing, one of the biggest benefits at this point is that recurrence risk and potential for prenatal testing. There's also the potential for future interventions. At this point, there's nothing specific for specific mutations, and we'll talk a little bit more about which mutations are more mild, more severe, et cetera. Right now, though, with the MEK inhibitors, like Dr. Thomas was talking about, there's nothing specific to specific mutations. but I think that will be changing, and I think we will have some more specific treatments based on and management changes based on which mutation you might have. So that could be an important reason to test in the future. And then the potential to reduce uncertainty with that Leigh syndrome, primarily. Some of the limitations in accessibility due to that cost and insurance, again, some of these labs are helping us to get around that a little bit. And then no change to management, just like we mentioned a couple times. And then there's also the potential to increase uncertainty with that 5% risk of not finding a mutation. That can really leave families in an interesting spot. They don't love that ambiguity sometimes, so it's important when counseling about testing. And then a trend that we've seen recently is that families with younger children tend to be more inclined to do testing than older children. And that seems because of that uncertainty with the potential for Legis, as well as just the uncertainty of the health of your child in general. If we kind of see that across the board for genetic conditions, parents with older kids tend to be more comfortable in the fact that their kid is doing well with whatever's going on, if they're healthy otherwise. And we see less of them opting for testing or pushing for it. So moving into genotype-phenotype correlation, what that means is how do your insides correlate to your outsides, basically? What is your specific mutation? Does that impact your risk for cafe au laits or your risk for neurofibromas, et cetera? So one of the biggest correlations that we see is with the full gene deletion. About 5% of people with NF1 have the whole gene missing. And we often see an overarching, more extreme phenotype. So earlier and more significant presentation of neurofibromas, definitely more significant learning delays, and an increased risk for the peripheral nerve sheath tumors as well as heart manifestations. Oftentimes we can see a bit of an overlap with Noonan syndrome, so sometimes we do more than just the chromosomal microarray. We might do a full RASopathy panel to make sure that we're not missing Noonan syndrome. And then there's definitely differences in facial features as well. So when I mentioned if we have a clinical suspicion for a full gene deletion, when we might jump to an array versus doing the sequencing del dupe of just NF, is we think about that primarily the learning and the facial features. So kiddos with missense mutations in NF don't typically have any differences in facial features. And like Dr. Thomas mentioned, do have learning delays, but not significant intellectual disability typically. So if we're seeing things that track, more with that gene deletion on those ends, then we might opt to just do the array right off the bat. And one thing that's important when you're thinking about that is what other genes are involved in this deletion. If you have a CNV or a copy number variation on your chromosome, then you're going to have other genes that are next to NF that are also missing. So these genes are important in understanding a child's phenotype and how significantly they might be impacted. We don't know a whole lot about a lot of the genes that are in the surrounding areas, but one that is kind of becoming a little bit more clear is called SUS12, and there is an increased risk for malignancies and learning delays. It is also an overgrowth condition like NF, so there's also an increased risk for cancer or malignancies. So you just got that compounded overgrowth going on. Again, no different in management recommendations. Even with these ones where we know there's an increased risk for malignancy, there's still nothing different that we do at this point in terms of management. Another more significant presentation that we see are if there are mutations specifically in codons 844 through 848. These are thought to be a bit of a hotspot, and there's a highly conserved amino acids in this area, so that means they're extra important for this gene to do what it's supposed to do. So we definitely see an increase in that tumor manifestation as well as the skeletal anomalies. We don't really see a huge difference in stature or learning delays, but it is, again, more significant for the risk for those malignancies. We do have a small cohort of this. There's more studies that need to be done in order to get more significant correlations. So at this point, again, there's no management changes with this, but we might just think about keeping more of an eye on if there is a plexiform or things like that. Another point to consider is that because of the small cohort there, and because that there wasn't any whole body imaging done, likely the tumor load is underestimated in this population. So again, I think that University of Alabama is continuing to do research, and hopefully we'll have a little bit more significant correlation soon. And then on the other end of the spectrum, there's also a mild mutation that was recently found, and the website or the link is down here and on my resources page as well if you want to look into that a little bit more. But it was a study with 135 patients, 103 of them were unrelated, and these people had no visible outward tumors. There were a couple of more low-grade or asymptomatic brain tumors, but nothing very significant, and there were no concerns for optic gliomas or spinal neurofibromas or anything like that. So much more mild and can potentially look a little bit more like Legius syndrome in the beginning, but it actually is technically NF with this more mild mutation. In terms of learning, there's still the learning concern there, but it is slightly less than the general NF population. We see 50% overall, and this was around 39. So we did have one family with this mutation in our clinic this year. Dad had some lipomas, but he didn't have any neurofibromas, and he really just had a handful of cafe au laits. So we weren't really sure what they had or what was going on in the family. We thought potentially Legius, and we kind of counseled along those lines. And he ended up having NF with this mild mutation. So it was interesting to think about it from that regard, when we're usually used to thinking about if you have a specific mutation, it might be more impactful, whereas this one is a little bit more mild. So again, no change in management, but can be really reassuring to families, similar to a diagnosis of Legius in terms of being reassured. So that's the genotype-phenotype correlation. And then just thinking broadly about some other questions and comments that I get from families or the things that come up when in counseling, like it's been mentioned a couple of times, we can't incidentally diagnose a parent. So that's an important thing to think about when you are counseling about NF in general. I also see a lot of parental guilt in this condition, both with inherited and de novo cases. Inherited, you kind of makes a little bit of sense. I feel like I gave this to my child, and we definitely talk through that you can't pick what you're passing down. You don't get to choose if you're passing down your healthy copy or the one that's not working. And de novo cases, we see a lot of, well, what did I do during pregnancy? What could I have done differently? Things like that. And again, this is something that happens at conception. So there isn't anything that you can do differently before, during, or after pregnancy. And that's something that can really alleviate, just saying that to a family can really alleviate that guilt. You can kind of see tears coming sometimes, but just an overall relaxation from some of those parents. The other thing that we get all the time, and Dr. Thomas mentioned this as well, is that NF2 is a completely different condition. I have families asking all the time, so can this turn into NF2? And the answer is absolutely no. It does not go. They don't switch back and forth. They're really very different conditions. And how I kind of see it as NF. They shouldn't have both be NF1 and NF2. I think it's a little bit misleading. And then, incidence is 1 in 3,000, like Dr. Thomas also mentioned. And, this is something that's on the more, it's rare in general, but it's not so rare in terms of genetic conditions. So we do see this rather frequently, especially with those de novo cases. And then one of the biggest things that I have patients coming in with are they've been referred from another provider, and they've had, our wait list isn't the shortest, and so they've had however many months to look at the scary things that are online. The information online is not all accurate, and it's very scary. A lot of the pictures that you see aren't even all NF. There are other conditions that can cause some of these growths and swelling and things like that aren't NF, and so they're getting poor information. The other thing to think about is, you're really getting the worst case scenario when you look online. These are the people who either have had no continuation of care, or the ones that just, are on that super severe end of the spectrum, where again, most people are on that mild end. So Dr. Thomas mentioned CTF as well as a very realistic and family-friendly resource. This is a place that I would send a lot of my families so that they can get good, realistic pictures and information. Just so it's just a less scary place. It's also a place where there are good resources for support groups and events and things where they can meet other families with NF and other kids with NF. So that can be really good for, you know, the young adults, teenagers to meet other people as they're going through all of that, as well as for families to talk and make sure that they're all on the same page and getting the most up-to-date research. So again, just please remind your patients that this is a wide phenotypic spectrum and most people are on the mild end. And if something does come up in terms of a complication, there's a fantastic team here at Children's, and we have a really good multidisciplinary program as well, so we can make sure we're keeping on top of all of that and keeping kiddos healthy as best we can. Along the same lines, Dr. Thomas mentioned MEK inhibitors. These have been fantastic, and our neuro-oncology team uses these pretty regularly and has been in part of some of those FDA trials. It's a fantastic treatment at this point to reduce those plexiforms and has been used for some optic gliomas as well. So things are moving forward in that regard and are changing families' lives, really. So that's been fantastic. There's some resources there for some of the studies that I mentioned, as well as ctf.org and the gene reviews for both Legis and NF, which are really good resources for primarily providers, not as a family-friendly of resources. So thank you. There's my contact information. Feel free to email if there's any questions. I'm happy to help out with that. So, yeah.
Awesome. Thank you both so very much for your presentation. It does look like I have a couple of questions that came in for our group chat. The first one is there more than one national NF support group?
Not that I know of. I'm sure there are a lot others, more regional ones on, Facebook and things like that. In terms of national, that's the one that I know of the most. There may be another one that I'm not familiar with, though.
Sorry, I'll interrupt. In the one article that references another one called Neurofibromatosis Network, it's out of Illinois. I don't know a lot about it, so there might be some smaller ones, but the CTF is really the large national one. But yeah, there might be some smaller ones, but the one, like I said, it's Neurofibromatosis Network.
Great. And can a person with NF1 be a solid organ donor?
I would say probably yes. If there's no neurofibroma, and typically we don't see neurofibromas growing, say, like in the liver or in the heart, those sorts of things. So more often than not, they're in the nerves and the surrounding tissue where they'd cause problems. But I would see no reason that you couldn't donate a liver, or heart, or kidney, as long as there's no evidence of NF involvement. Which would be rare if you ever saw it. So I would say probably yes. I've not heard that it's contraindicated, but I have to say I haven't had that question before. So.
Great, thank you for that.
Uh-huh.
I'm still reviewing our chat room. It doesn't look like we've had any other questions come in. I'm happy to give just a few seconds here for anyone who has final questions for Dr. Thomas or for Shana. You're welcome to submit those now.
I would make one comment that we didn't probably make too clear, and that not only is there a lot of variability between families, but there's also a lot of intrafamilial variability. So even if you have a parent that has NF1 that may be more mild or more severe, that also doesn't predict what the child will be like or what other family members will be like. So I think families that, particularly if a parent's affected, they've had complications, it's hard, but we can't predict even within a family the severity for a child. So there's both inter and intrafamilial variability, and it's significant. So